Women, historically, our sexuality has always been criminalized. 85 million women today are suffering from common conditions, 7 years to get the right diagnosis and get the right treatment. Medicine is a system that refuses to change. We're failing our patients, we're failing ourselves.
Why do most urologists tend to take care of more men than they do women?
It's a culture thing. We have these really clear-cut lines. We just do men's sexual health. And when we went into women's sexual health, this is a stark difference in terms of access, in terms of research, in terms of care.
Clitoral anatomy has been incomplete up until very recently, but you still believe there's more to be discovered.
Oh, absolutely. There is minimal data in women's health. There's so much variation in vulvar anatomy. Many textbooks don't show the variability.
Why do we still tell women it's all in their head?
Medical misogyny, healthcare hates women. The data shows it. The patient's experience shows it. The training shows it. At some point, we have to say the quiet part out loud.
The Disruptor podcast is for informational purposes only and does not constitute medical advice. Views expressed by guests are their own. Consult your healthcare provider before making any medical decisions. She is a double board certified urologist and fellowship trained medicine specialist who is rewriting the blueprint for pelvic health, often referred to as the vulva queen. Yes, she is. Dr. Maria Uloko has dedicated her career to dismantling the shame that prevent people from accessing life-changing care. She currently serves as an assistant professor of urology at UC San Diego, where she specializes in female sexual dysfunction, hormonal health, and complex reconstructive surgery. Beyond the operating room, Dr. Uloko is a digital pioneer leveraging artificial intelligence to democratize medical knowledge through her Vulva AI platform. A frequent keynote speaker and media contributor, she is on a mission to ensure that every individual feels empowered, informed, and entitled to pleasure. As a founder, I love founding stories. So I want to know how you went and why from the traditional urology to being this unbelievable vocal advocate for sexual medicine. So do you want to tell us a little bit about that?
Yeah, that's a fantastic question. I started as a urologist. I think we'll start back at medical school. I started medical school when I was 17. I had no idea actually what I was going to do. I just knew I wanted to be a doctor and I wanted to help people. And through a series of fortunate events, I found urology. And again, I'm such a big believer that representation does matter. I met my first female urologist and I was like, I did not know we could do that. I had no idea that women did urology. So then I took a rotation and I loved it. And I was like, okay, this is what I want to do. And I got into urology and then I found sexual health throughout my journey. And I think one of the things that I love about urology is that it's kind of its own closed ecosystem. So say someone has prostate cancer, we diagnose their prostate cancer, we treat the prostate cancer, and then we cause all of these side effects, whether it's incontinence or leaky urine or sexual health side effects. And then they come right back to the urologist and then we help fix them. And those are actually the conversations I loved. Was like, okay, once we've saved your life, now let's focus on what your quality of life is going to be. Now it's let's make sure that you have a life worth living. And I love those conversations in sexual health. And obviously urologists spend most of their time in men's sexual health and not a lot of them do women's sexual health. And then I met Dr. Irwin Goldstein at a conference and he just really saw something in me and was like, I would love to have you as a fellow. And as 0.02% of Black women, no one in urology is had ever said I want you. And that really also really spoke to me. And then also a year in San Diego, please sign me up.
Not a bad thing. I did a very abbreviated preceptorship with him and literally, I think I had been in practice 10 years already, mind blown as to the things that he was doing. And it was amazing because I almost get giddy talking about it. You finally feel like you've met your people. You know what I'm talking about?
Yes.
Yeah, you're practicing and everyone's like, what are you talking about? And then you go to this conference and then you spend even more time with these experts and you're like, oh my God, I want to take all of this information, education, and tools back home and help my patients. And so I want to go back to something that you said though, because I think urologists have a superpower that I love in sexual health care. I always tell my patients, I'm really good at the gynecology and the sexual health care for women now with the additional training, not with the training that I got. But what I love about you guys, because where I am limited is when the patients say to me, okay, well, now you've fixed my painful sex, or you've, helped me with my low libido or my orgasm or arousal, whatever it is, can you help my husband? And I'm like, no, actually I can't. I can give you referrals, but I am not trained in men's sexual health. I'm not a urologist. So that's what I love. But then why do most of your counterparts why do most of your counterparts, urologists, tend to take care of more men than they do women? Is it a comfort thing? Is it a data thing? Is it an insurance reimbursement thing? Can you tell us more?
Yeah, I think it's a culture thing. We have like it's the gender binary, right?
Yep.
Urologists take care of men, sexual health, and gynecologists, in theory, like should take care of women's sexual health.
There's
And
some of us out there. There's some, but I agree with you in theory.
Yeah,
Yes.
in theory. So like, our curriculum when I was studying for boards and all of my board certifications, all of them, like their sexual health is ingrained it's ingrained in it. And then also, insurance reimbursement. When with the advent of Viagra and with the advent of implants and all of these things, there's a lot of advocacy, there's a lot of legislation, there's a lot of policies around the advancement in sexual health and then the coverage in sexual health too. So it's actually a very lucrative business for our organization. And so we have these really clear cut lines of like, okay, we just do men's sexual health. And then Irwin Goldstein was this unicorn. And he said, no, let's do it all. Yeah. Right? And he said, let's do it all. And he created this fellowship that only less than like a handful of people have ever done. And, and I think the beauty of urology is that because we have kind of that North Star of men's sexual health and seeing how easy it is for men to access healthcare, which is a right? Sexual health is a right. It's a beautiful thing.
It's a basic human right, according to the World Health Organization. Yes.
And so we see that.
Yes.
We saw that. And when we then went into women's sexual health and we saw, oh, wow, this is a stark difference in terms of access, in terms of reimbursement, in terms of research, in terms of just, care. And we're just like, oh, okay, well, now at least we have a goalpost of like, okay, we want it to at least be equal. So then how do we raise the bar for this access, this education, this training? And I think that is actually my North Star. Was I saw that there was this huge gap. And I just crunching the numbers of like understanding that I am one person, and I created an insurance model, and I did 15 months. I saw almost 2,000 patients. I had a 1.5 year waiting list. But if we actually think about how many people potentially can have these issues, it's like 960 million people in the world. And I was like, okay, we need to be able to scale. We need to figure out how we scale this education, this technology, this resources, all of these things. And I had actually been dating a couple of guys in tech, and I got to see them solving problems. As a problem solver, I was like, whoa, you get up every day and there's a problem and you solve it, instead of like in the traditional healthcare model, there's a problem. Let's come up with 6 different committees. Then those committees will come up with
510 meetings.
Yep. And then at the very end, they're like, oh, we can't do that. And it's like, no, you can. Actually,
and no one is speaking the same language. The business people, because for you and I who are founders, you learn how to speak clinical, like in the OR in the exam room, but also in the boardroom. So I want to go back to something you said, though, that was very prolific. So about urologists. So I avoided Sexual Medicine Society like the plague because, as a gynecologist, you hear it's the penis conference, right? Like I always went to ISHWISH, right? The International Society. So I went one year, and I will tell you, still one of my favorite lectures ever was given by a urologist, and it was called, instead of like, oh, the elephant in the room, it was called the penis in the room. And it was talking about their recognition and their career path of, oh my God, we treat erectile dysfunction, everything that you said. And that for men, it's so easy. And that while she was taking care of all her male patients, she realized no one stops to ask, because she was assuming the same thing, right? The gynecologists are taking care of the female partner if it's a female partner. And she was like, no, all of a sudden, we've fixed the erectile dysfunction, and maybe this woman has severe GSM or HSDD or or an orgasm dysfunction. And no one even asked her if she was ready or prepared for any type of intimacy, let alone, penetrative intercourse. And so it was such an eye-opening lecture for me. So do you have an aha moment when you realized that medical education, particularly for sexual health, was so lacking?
It was in fellowship. I took my fellowship because I came out of residency with a really strong foundation in men's sexual health. I was like, I got this. I literally thought my year in San Diego was going to be a blow off year, just like a year to like regroup, recharge, be in the sun. I did my training in the University of Minnesota.
Really cool cases, right? Because people come to him from around the world. Like that's, yes.
I really thought like I was just going to supplement what I already knew. And then actually it was like drinking out of a fire hose. I was like, whoa, what? Like, how did I just, and the thing is, a urologist, we are in the vulva. We are like doing surgeries and on female anatomy, and we're doing all this stuff, but I didn't realize that I never learned what those names were. I never learned like the hormonal pathways for this. I never really learned true anatomy and physiology. And then I also never learned why they were important. It really was just as a urologist, okay, here's the urethra, here's the vagina, here's the structures that you don't want to hit and cause issues. But that was it. There was never conversations around function. There was never conversations around sexuality, hormonal regulation, all of these things. And so during this fellowship, I'm like, and then also one of the things I loved about the fellowship is that every new patient visit is 4 hours. And like you're spending 2 out of the 4 hours with the patient, and you're really getting to hear their stories and sitting down with them and hearing their stories. And so understanding how little I learned, and even though I had an amazing medical school, amazing residency, and then understanding how little I learned, and then hearing how deeply it impacted the patients was just so eye-opening. And I'd have patients that would be suffering for 10, 20, 30 years with symptoms, and all they ever really needed was a simple vulvar exam, a simple sexual health evaluation and a vulvar exam, and you could relieve and alleviate their pain and their whatever dysfunction that they had.
Suffering, isolation, yes, embarrassment, loss of relationship, loss of marriage. And so what you're referring to is what I learned out there too. It's like the biopsychosocial model, right? You have to take everything into account, their biology, their medical history, their own biases about sexual health care. What is going on in their life? Like, are all they stressed out about work? Are they all of a sudden caretakers to their elderly parents? Have they been struggling their entire times? Were they taught that sex is dirty or it's not okay outside of marriage? I mean, there were so many things I learned about the art of biopsychosocial medicine through sexual health care that has helped me even with hormonal health and, perimenopausal and menopausal patients. But why do you think that when we approach women, rather than taking this biopsychosocial model, why do we still tell women it's all in their head?
Medical misogyny. Like if I were like medical sexism, medical misogyny, healthcare hates women. I'm so sorry. I said it with my chest, and I'll say it with my chest. The data shows it. The patient's experience shows it. The training shows it. At some point, we have to say the quiet part out loud. Like, we can't just like keep skirting. Oh my God, it might be. No, it is misogyny through and through. And if we think about and I'm a medical historian, I'm obsessed with history because it really.
I did not know that about you. I love that. Okay.
I love understanding. I mean, I'm a Virgo, which means I'm a professional hater. And so like whatever I see something that doesn't make. I'm married to
a Virgo. I'm learning more and more. You have many layers, friend.
Yeah.
Okay.
whenever I see something that's not working, like I don't question systems that work, or other than like, oh, if it's working, like, all right. But if a system isn't working, I think it is up to us, the people that are actively engaged in the system, to question the system. And I think the first place to start with questioning the system is to understand the history of the system. And medicine is it's a system that refuses to change. It is obsessed with tradition. It is obsessed with it's obsessed with doing things exactly how it's always been done. And so then I always ask the question of like, well, who created the system and why was the system created that way? And so if we're continuing to propagate systems of harm and abuse and of sexism, of racism and all these things, we're failing. We're failing our patients.
And we're
failing
part
ourselves.
Of the problem rather than being part of the solution.
Yeah.
Yes.
Yeah. And if we think about just like how women historically have been viewed, our sexuality has always been criminalized. And like, if we also then think about who created medicine, it was cis white men. So now you're bringing culture and science, and we're trying to create objectivity. Science isn't objective. Like, we want to believe that science is objective, but objectivity actually happens in the intersection of culture and who is the person actually being objective, right? And so it's actually deeply subjective objectively. And so if a culture is deeply sexist against half of the population and doesn't think that they deserve rights and does that, you're then building a foundation of science based off of those deep principles. And even though we say like healthcare is egalitarian, it's all these things, it actually isn't. And as someone that trained in men's health, I can stand 10 toes down and be like, there's an absolute difference in how your genitalia impacts your access to science, to education, to funding, and to care.
To everything, for, like you said, funding, the way you get care, how quickly you get medication in the ER, delays in diagnosis, whether you're going to live or die from a heart attack. So this great, and even the last 2 decades, what we've done to women with withholding hormone therapy, particularly. Can you imagine letting men walk around with brain fog, joint pain, weight gain, insomnia, hot flashes, no sex drive, and erectile dysfunction for 2 decades?
Absolutely not.
Or how about, that's what we did to women, or slapping a black box warning on a localized product that actually can save lives, that didn't have a singular piece of data to support that any of those warnings, endometrial cancer, dementia, happened from localized estrogen. In fact, we can save lives, and we were costing the US healthcare system so much money, unnecessary hospitalizations, exposure to antibiotics, misery and quality of life, women who gave up on their sexual health care. And I met a woman last week, an NP, whose mother died from urosepsis because she was told she should not be on localized hormone therapy because it was dangerous.
I actually legitimately cannot. It does not happen in men in urology. It doesn't happen in the urologic space. One of the things I love about being a urologist is that we are so data driven, and we're also very innovative. And then also we're and the reason we can do that is because we're well resourced and well funded. And so, even in my 5 years of urology residency, there were certain things that, like, let's say testosterone. So prostate cancer and testosterone, we know they go hand in hand together. And so after a patient is treated for prostate cancer, typically what happens is that they cannot be on testosterone. That was when I started training in 2015. They cannot be on testosterone. However, prostate cancer affects patients of a certain age. And so 60 and 70. And so around that time, they're also getting low libido or low testosterone. And so now they're coming back symptomatic, and they're reporting all of these symptoms, and they're miserable. So again, we're giving you life, but then we're making your quality of life not worthwhile. And so urologists banded together and did a clinical trial and said, hey, is it safe to give testosterone to men who have been treated for prostate cancer? In 2021, within 6 years, we now have data. We now have different conversations. We now say you can give men who have been treated for prostate cancer and they have they passed and successfully cleared the cancer testosterone. What? That is what I'm used to. That is what I'm used to. That is the conversations. That is the science. That is the innovation. That is the advocating for patients that I am used to. And that's what I love. I love, like, I don't care what gender you are. I love my patients. I love helping my people. Like, those are like, to have a privilege to take care of humans is something, it's a dream that I had since I was a kid. So I literally do not care what your gender is. I'm going to help you through and through. And so when I then went into women's health,
rather than myth. And that's what I love. And so I wish the same thing, not I wish, you and I are going to continue to do the work, so it does happen, that we move forward with women's healthcare with data. And as long as women are making decisions based on data and not myth or fear, I'm good with whatever they decide, because you and I are all about bodily autonomy for everybody. It's why you shifted, or not shifted, but you also added to your crazy resume that you are now a founder and you're kind of building in this tech space, educational space, and you're building Vulva AI. So can you tell us in a couple, because I know what it is, but tell us in a couple of sentences, what you're building there and what your mission is with it.
Yeah. So with Vulva AI, what we're doing is we're building the infrastructure in women's sexual health and then vulvovaginal care delivery. So the three biggest problems that I noticed that I knew that I could solve. There's a lot of problems, y'all. I can't solve them all. I'm one woman and I can't solve them all. But what I did notice was that there is no standardized curriculum in women's health, particularly around vulvovaginal care delivery, whether that's in understanding what the diseases are, understanding anatomy, understanding how that anatomy then works, then understanding and creating diagnostic models and frameworks, and then treatment models and frameworks for very common conditions like overactive bladder symptoms, pelvic pain, recurrent urinary tract infections. Like 85 million women currently today are suffering from those conditions. 7 years to get a diagnosis, $20,000 out of pocket cost to get the right diagnosis and get the right treatment. And
wait, say that one more time. Women are waiting how long to get a correct diagnosis?
7 years, particularly in the pelvic pain space, 7 years to get the right diagnosis on average.
This is pain and misery. And it's not what I want people to understand about these pain conditions. And that's what women tell me. It's a head to toe, because it negatively impacts their mental health. It negatively impacts their confidence, their relationships, and just their comfort level. If you imagine being in pain all the time, or every time you try to ride a bike or have intercourse or wear tight clothing, or you're irritated, like, it is maddening to me. If I ever hear one more time from an investor or a researcher or anyone else, well, it's not going to kill her. I'm like, yes, it can. And how many medications do we make for men for quality of life? Why do we have to prove it's life or death? I mean, we'll give you the data, but why is the burden of proof so much higher when it comes to women? It's crazy to me. And you said something more.
Misogyny.
You posted something recently too, because I know this clitoral anatomy has been incomplete and inadequate and sometimes even wrong up until very recently, right? But you still believe there's more to be discovered.
Oh, absolutely. So I feel very fortunate to be part of the clitoral history. So Dr. Helen O'Connell was the first, was a urologist herself, and she was the first one to actually define the 3D structure of the clitoris. And then myself and our research group, Paige Isabay and Dr. Blair Peters, we actually defined how many nerves are actually that innervate the head of the clitoris. And then there's recently a new study that was done that looked at how those nerves actually then map throughout the clitoris. And this is actually what I love about science. Like, this is what science discovery is. So I actually push back so much around when people are so stringent about needing to do things with data. It's like, we need more data. We need more data. It's like, well, someone has to go out and create the data, y'all. Like,
and someone has to do it first.
Yes. Like, someone has to go and create the data team. And like, if we understand the difference between men's health and women's health research, there is no data. I mean, like, there's actually, that was an exclamatory statement. There is minimal data in women's health. So then to say I'm only going to practice women's health just with this small amount of body of data is actually wild, because we're actually then preventing women from getting care, because that you're actually like living in this fallacy that all the data has been done. It's like, no, baby, we're still just defining anatomy today. Like, and so,
is that clitoral model, is that going to be part of Vulva AI or no?
yeah, yes. So like I said, I'm obsessed with anatomy. I'm obsessed. I literally want to make this care scientific, because it's like, honestly, it's unfortunately old wives' tales, just vibes, like, wear cotton underwear, shower after you have sex. Like, we tell people, patients, all of these things that aren't rooted in science. And so I actually want to give people an actual diagnostic, deeply scientific and backed curriculum on how to actually diagnose patients.
You are also including different. So I was part of, I think you and I bonded over this. I was part of Peanuts reframing and renaming revolution to take out harmful medical terminology, but then also to have medical illustrations that were more representative. And the most common example I can give you is, I don't think I learned how to correctly diagnose a jaundiced baby in obstetrics of different skin tones. Like, I may have missed it in a darker skinned child, like one of my own, or one of a baby like that looks like you, because I only learned what a jaundiced infant or baby looks like in a Caucasian from a Caucasian mom. And so are you training your algorithms and your AI to be more gender inclusive and more inclusive of people from different backgrounds?
Baby, absolutely. Like this is what happens when you have a Black queer woman designing things. So
I love it.
Like, I have a very intersectional lens in everything that I do. And so one of the big issues around vulvovaginal education and knowledge is that there's no images. Like, there's not enough images for people to actually see what are the potential variabilities of vulvas, what skin colors, what skin types, what different labia, what different clitoral, like there's so much variation in vulvar anatomy. And most of the textbooks are very like one size, one skin color, one labia size, there actually have been studies that actually show that many textbooks don't show the variability. So even if you were someone that really wanted to go in and learn and do the things, you're then going to textbooks and curriculums that actually aren't showing you what you need to know. So then when you're out in the real world, you're like, I think this is normal, or maybe it isn't normal. And so this is what I love about our ability to utilize technology and AI, is that we're actually able to create these images and build these images with the understanding that there is not enough images just in the general lexicon.
So I want you to give our listeners an actionable piece of advice. So so many times doctors who either haven't been trained in the appropriate anatomy or just check labs or don't know how to do the diagnostic workup will say to a patient, you look fine, your labs are fine, I don't know what to do. Or they'll swab someone and they'll get normal flora and they'll treat them with antibiotics and they don't get any better. And then there's a cycle of, well, now I have a yeast infection, so yeah. What do you say, or what's your clinical rebuttal to a woman or to for them to say to their doctor or their provider to say back to them when they are dismissed in that manner?
Yeah, this was such a big issue that so many of my patients prior to me has faced. And I just sat with it of like, okay, I've had my own healthcare issues throughout the healthcare system. And the only thing I knew that helped me was, first and foremost, I've been in healthcare since I was 17. And so I also know the dangers of the healthcare system. And because I know the dangers of the healthcare system, I don't feel bad about being a bitch when I have to go into the healthcare system. I do not feel bad about advocating for myself. I do not feel bad about being vocal. And the way I am able to be respectful, but vocal, and then also presenting the data, because I think there's this fallacy of deep trust. And I wish we had this of like, well, yeah, of course they know everything. I should just step back and sit back and not like let them cook, But honestly, like you actually have to be a very active participant in your healthcare system because there is so much risk of bias and mistake. Healthcare workers, the healthcare system, it's run by humans and humans are fallible. Even though they're trying to do the right thing always, they are still fallible. And so you have to be the one to be like checks and balance and be like, whoa, 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 what are we doing? Whoa, whoa, whoa. Actually, the guidelines don't state that. And I protected myself through the healthcare system by knowing the data, by knowing how to go to the research, by then also feeling very emboldened to say be like, absolutely not. Actually, like, this is what I should deserve. This is what I deserve, right? I knew what I deserved. And so I think one of the things that many patients don't know is that they deserve care, that their symptoms are real and valid, and there are actual ways to treat them. A lot of what we call recurrent and chronic aren't recurrent and chronic. They're actually just misdiagnosed. And so I always
have gone untreated or incorrectly treated. Yep. And that's why they're still there. Yes.
Yep. So I always tell patients, trust yourself and then go to the research. And so as someone that's also a problem solver, even though I'm like, yeah, go to the research. Where's the research? How do I get to the research? That's what we created our patient advocacy tool for. So our second arm of what we can do is our patient advocacy tool with Vulva AI is we actually are kind of your patient advocates as you go through the healthcare system. So say that you've had pelvic pain and you're trying to get an answer, you take our symptom quiz. We actually teach you all the things that it could be based off of your specific answers. We build what we call the differential diagnosis, which is like, hey, based off of your history, your risk factors, you might have these things. Let's teach you what these things are. Like, really wanted to get you, like, Bill Nye the Science Guy was like Miss Frizzle, and Bill Nye the Science Guy are like my heroes. And that's how I fell in love with science. And so I want people to fall in love with the science of their bodies. And so we create content around that of like, hey, what is pelvic floor dysfunction? Hey, what is like hormonally mediated vestibulodynia? And then we get deep into the science. We then tell you, okay, this is what your doctor should be ordering. They should be ordering a full hormonal panel. They should also be doing a vulvar exam. Wait, what's the difference between a vulvar exam and a pelvic exam? What is the vulva? What should my vulva look like? Actually, we actually teach patients how to do their own exam. Look at your own vulva. Most of the symptoms that you are feeling, you can actually see on exam. But because there's a cultural shame around the vulva, there's actually no pictures. People don't know what to look for. They don't know what they're looking at. They're like, I think it's red, but I'm not sure if it's supposed to be red or pink or da 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 da. So we actually teach you all those things. And then we actually teach you, like, if this, then that. If you have these labs and these symptoms on exam, this is the treatment that you get. So now that patient that came in just knowing something hurts, but I don't know what it is, they now come in saying, hey, something hurts. It's been going on for this long. I used to take oral birth control, or I have a history of like constipation and like high stress and like high risk for pelvic floor dysfunction. And so now they can have an educated conversation with their doctor, and they can have a conversation with the doctor from an informed place and say, and I would like these testings. And also, patients don't know that they have a Bill of Rights. And like in that Bill of Rights also is like they can advocate for a lot of things. And so we actually give them
their own healthcare. Yes. And what you do with this is you make them partners in their care, rather than, because you remember the old adage, right? That your pelvic exam used to happen to you. And that's, I think a lot of women have said to me, when they go up in stirrups, they feel like they lose control. Yes. So, and I remember ACOG a couple of years ago finally said, use a mirror. We did vulvoscopy at her MD, where we would use the colposcopic device, which we also let people see their cervix. So they weren't so scared, because people tell people, abnormal pap smears are pre-cancer, and that word is so scary. So it'd be like, this is all that's going on. And, let me show you. And so we would use that same technology. And if they wanted to see their vulva, we would examine the vestibule, and then we'd also do the Q-tip testing. And that way we could not only show them if there were any, abnormalities, or, they could show me or our providers, this is where it hurts. And then we could really focus in on that area and say, oh my God, look at why. These are the anatomic changes. It's probably consistent with, X, Y, Z. Sometimes we would take a biopsy, just depending on what was going on. I can't tell you how many people cried, like tears of relief. I wouldn't say joy,
Yeah.
relief, because they finally felt believed and someone took them seriously rather than, because I feel like most gynecologists, we're not trained how to do an appropriate vulvar exam. You just put that speculum in, you're going for the pap smear, you're looking at the vaginal walls if you're good and if you use the right speculum, right? Because most of them were not clear back in the day. And so you wouldn't look at the walls really well. And so I love what you're doing is you're empowering women literally to become the CEOs of their own healthcare using tech and bringing it to them. That's the other step that I love about what you're doing. And that's why I love femtech so much, particularly when it's accessible, because I feel like women have suffered long enough. They shouldn't have to look for answers in a, like a needle in a haystack. And so if we can provide this and make it accessible, they go empowered and educated to their doctor's offices. We also make it easy for those providers who have not had the level of training that you and I have had. So at least they can be productive together. And because this, most doctors, you and I know, went into this to actually help people. It's the system that's broken and not allowing them to practice. Like you said, 4-hour visit. I'm like, I thought I was lucky with the 1-hour visits we had at her MD. I couldn't even imagine. You could get a lifetime of stuff done in that.
It was awesome. It truly changed my life. Again, just to understand that everything we do is made up. Like everything that we accept in the healthcare system is made up. So you actually have the ability to dream of a better system, so many people. And again, I have always been like, I question everything. And I was a very difficult child.
My nickname was Question Machine as a child. Literally pushed back, challenged. Why does it have to be that way? No.
Yes. I was a deeply sensitive kid, very squishy hearted, and I just wanted to help people. And again, like I say, I feel so privileged that I get to sit here and help people and do the things. And so whenever I'm seeing things that don't make sense, that are directly impacting humans and harming them. Why? Because all of this is made up. So we actually then can use, and this is the beautiful thing about like doctors are really smart people. People that go into healthcare are really smart people. So instead of us wasting our brain space to follow the rules, what if we used our brains to build a better world, to build a better system? Some of the most brilliant, creative people I know are doctors. And so
and a lot of them will toe the line though, because they don't want to be troublemakers. But that's exactly, somebody was like, what is disrupting? I'm like, disrupting is killing or destroying what's killing us, or disrupting is building something to avoid what is killing us. You disrupt the systems that do not work for us, and the status quo never served anyone, particularly women. So what is one myth you wish would die tomorrow?
What is one with, that estrogen is the most important hormone for women. Testosterone is just as equally as an important hormone, and particularly for our vulvar health, our bladder health, our pelvic floor health, our colon health. Testosterone is a very important hormone. And we give medications that strip us away of our testosterone, which then causes so much disease. And then patients get stuck in a cycle of misdiagnosis because we only understand estrogen's impact on the body. And so then we then tell the patients, something's wrong with you, but we don't know what it is, when in actuality, a lot of what is driving their issues is a testosterone deficiency. But doctors are like, well, no, women don't make testosterone. It's like, baby, we do.
Oh, they're still telling my patients, they're coming to me and their doctors are telling them, why are you asking me for a male product? Or why are you asking me for a male hormone? So the Testosterone Project is a non-for-profit who I sit on their advisory board, but non-for-profit who are trying to do the work to create the advocacy, to give patients and the general public all the tools, letters, everything to get the FDA to finally get products across the finish line for women. Because like you said, it's not limited to sexual function. We are getting more and more data that testosterone helps with so many other things. And I agree with you.
Yes.
We need less if we identify as women than our male counterparts, but it's equally as important for us and for our health as it is for men. one book that you think every woman should be reading right now? Well, first of all, can you believe the number of healthcare books that are out there? Like, I never thought that I would see all these New York Times bestsellers in the women's health category. So that makes my heart so happy.
Yeah, one book that I think everyone should reading. Let's see. Hold on. It is actually, so Megan Rabbit is an amazing, I'm looking up the title of her book right now. Megan Rabbit is an amazing journalist. And she spent almost 3 to 4 years interviewing physicians, experts in the field, scientists about the entirety of women's bodies, like from head to toe throughout the lifespan. And she wrote, the book is called The New Rules of Women's Health. It is a manifesto. It is so big. It is so brilliant. It is so bold. It is so full of deep, rich context. So what she did, which is revolutionary, what she did, because when we think about what we know about the body, what we actually know about the body is the men's body. And so we know about the men's bodies we know about the body, quote unquote, from head to toe, but that's actually men's bodies. What she did was she took there are brilliant people doing research on women's bodies, but just in all different areas. She took all of that information and made this amazing manifesto. I love it so much. I am in it. And also, I love it so much. I think one of the things I'm really stressed out about a lot around social media was a great tool for advocacy, but because the algorithm doesn't favor nuance. The algorithm doesn't favor nuance. It favors exclamations.
Yes.
You should be taking hormones. It's well, not everyone, but we should have the ability to. Let's have a nuanced conversation. And I think the algorithm has impacted us is our ability for nuance. And I think, yes, we are doing a lot of advocacy. We're doing a lot of movement, but I think patients are still confused. And so
patients are so confused because there's so much information out there, and then you don't know if it's a trusted resource or it's not. And some of the more traditional providers don't trust the more forward-thinking providers. And then there's influencers, and who I love they're just talking about advocacy, but when they start crossing the line of practicing medicine, then I get concerned, and I'm like, you shouldn't be telling people how to dose medication because you're not a provider. But listeners, I interviewed Megan Rabbit, so I am so excited, and I did not realize you were in the book because I have not read it yet. I have been gifted all these books, but I agree with you. She was a fantastic guest.
That's my girl. She's awesome. I'm a huge fan.
I agree with you. And she was featured, I think Maria Shriver's, either Sunday, I can't remember. But yeah, the book is getting a lot of positive accolades and a lot of attention. And I'm loving that women's health is such a priority now in the press. Because think about it, the press did us dirty with the, after the WHI. So we didn't do great things in medicine either. I own our responsibility in this mess that we call healthcare. And I want to go back to something you said in the beginning. I went into healthcare very mission driven like you, because I nearly lost my mom when she was 45. And I used to say, I'm going to revolutionize women's healthcare. And, I sold my educational platform and I scaled my company. But then now I realize, I'm like, if I just leave it a little bit better than where I found it, that's enough for me, for legacy and for teaching the next generation so that they don't have the same gaps that we did. And when I say the next generation, I mean both providers and patients. So they have the tools that you and I talked about. So they have a very productive conversation in those clinical exam rooms, because not everyone has had the access to the advanced training that you and I have had. So what does that forward future thinking in 5 years? I'll be retired. I don't know about you, but I'll be double nickels, 55. So that's my goal for retirement. What does a disrupted healthcare system look like for you, or what does that mean for you?
Okay, in 5 years. All right. So Every single doctor, no matter what specialty, knows about vulvar health, knows vulvar anatomy, knows vulvar physiology, then knows what all the things that can happen to the vulva, knows then how to create a diagnostic framework, and then knows how to treat. Much like I, as a urologist, have to know about the heart, the brain, like all of these different things. It is a body part, and as doctors, we need to know body parts, no matter what your specialty is. So point blank, period. Secondly, patients understand bodily autonomy. They understand their bodies. Like the vulva is such an interesting thing. Like when a man comes in with penile pain, he's looked at it. We've talked about it. Like he's studied it extensively. For a lot of patients coming in with vulvar pain, they're like, I've never even looked. I never thought to look. I don't even know what I'm looking at. There's a discongruence here in just general understanding of our bodies. And so I want the patient experience to be like, oh yeah, I have pain. Oh, I look down there, it's red. Oh, I actually took some birth control, or I've been having a lot of stress at work, and I had a really bad yeast infection. I think I could have all these things. And coming in informed, so that now the healthcare visit is shared decision making from a place of education and empowerment on both sides. And then the rates of 7 years to get a diagnosis goes down significantly. The rates of recurrent UTIs, the rates of pelvic pain, we start renaming things actually just acute pelvic pain and then chronic pelvic pain. And actually, like, the acute is like, I had some pain, I got it treated really quickly, and now I never have pain again. And then the chronic is the actual, like, only 10% of the work that I do is actually chronic. 90% is acute pain that was just misdiagnosed. And so now we actually could be breaking people of the cycle, actually then creating better systems and structures around what truly is chronic pain, and not just everyone just being misdiagnosed or delayed treatment. And then also 5 years from now, we have policies in place where people that do gynecologic care, because that's myself as a urologist doing women's health, or gynecologists doing women's health, are paid appropriately.
Thank you. Say that again. So they don't have to see 50 patients a day and have the time to do the visit that you deserve. Yes.
Shocking. It is an egregious, and honestly, as all physicians, no matter what specialty, we should be so mad that you are getting less reimbursement for taking care of women. That should not be a gynecologist problem. That should be like, as your colleagues, as the people that trained with you, we should also be just as mad. Like, this is unreal. And I had no idea that I could do the exact same procedure as a gynecologist, and I would make more money.
Get better.
Yep. Making the exact, just because my lobbying group is better as a urologist. And then when I do a surgery on a penis versus when I do a surgery on a vulva, even though a vulva is more technically challenging than a penis, I lose money doing vulvar surgery versus gain money doing penile surgery. And it's just like, when I say medical misogyny is real,
well, then it's forcing all these really super talented physicians to stop taking insurance. And it's like, why? It's why I had a medical spa in all of my locations, because I had to offset the cost. We were losing on the hour-long visits by the time you paid the provider, your med mal, everything. So I had to think of creative ways to diversify, revenue, so that we could offset the cost of the longer appointment times, because that's what women deserved. But as doctors, like you said, we shouldn't have to fix that. That is, insurance companies should be fixing that and helping women and helping people who pay for their insurance premiums, who are not getting covered in the manner that they should, or having to. The worst is when they force us to break up these appointments in 20 different visits. Well, we're not going to cover that as part of the annual, or we're only going to pay this for the modifier, making it so complex for everyone. It's crazy. So I have to, I feel like you and I could talk for hours. And I'm going to encourage you, those of you who are listening, to actually watch this one on YouTube, because both of us are so passionate. We're jumping into the screen. I wish we could have done this in person together. But I want you to tell everyone where they can follow you and your company, Vulva AI, and keep up with all the fabulous things that you're doing.
Yes. So you can follow me on LinkedIn, Maria Uloko. You can follow me on Instagram at Maria Uloko MD. Also on Instagram at Vulva AI. My company is Vulva AI. We have a website. We also have a waiting list, and we also are opening our pre-seed round for investors that are interested and you want to revolutionize women's health because the market is infinite, because everyone with a vulva will experience these issues, like, come on over. And for patients or consumers that are suffering and need help and need answers, sign up for a waiting list. For doctors who are interested, we have courses out already that you can learn and educate yourself. Come over, say hi. We love learning. We love meeting the people that we can potentially impact and help.
Thank you so much for being a badass disruptor and for being here with me today. And to all of those of you listening at home, I want you to remember that you can become the CEO of your own healthcare. Thanks, girl.